Hi, so my name is Sirui Ma. I am a PGY2 general surgery resident at Rutgers, New Jersey Medical School in Newark, New Jersey, and thank you for giving me this opportunity to present my research on minorities facing reduced access of minimally invasive techniques. Today we'll be discussing gastrectomies. So this is the disclosure side. I have no conflicts of interest or other disclosures regarding this presentation or this talk that I will be giving. So cancer remains one of the bigger public health issues of our nation today. So gastric cancer is the third leading cause of death in men and also the fifth leading cause of death in women worldwide. There is a disproportionate number of men affected by this compared to women at a 2-to-1 ratio. So as we know, the etiologies of gastric cancer are due to H. pylori, consumption of cured foods and smoked meats. Also, it's associated with obesity, smoking, alcohol, and socioeconomic status. And we see that the incidence of gastric cancer is reduced now with improved surveillance and detection, and also mortality rates are also going down due to improvements of treatment. So for the current guidelines of treatment of gastric cancer, they recommend a radical resection of the stomach with 5 to 6 disease-free margins along with a lymph node harvest of 16 or more. We see that minimally invasive techniques such as laparoscopic and robotic procedures are becoming more prevalent. In the literature, it's been shown to have shorter lengths of stays by 1 day, also fewer complications, and also comparable or greater lymph node yields. We also see comparable negative margins as well as mortality rates when comparing open and minimally invasive techniques. So I'm part of a research group which has identified some racial disparities with other laparoscopic surgeries. Given the incidence of gastric cancer, we decided to evaluate the data on gastrectomies. So for our materials and methods, we took the database from the American College of Surgeons, NSQIP, from 2012 to 2019. We took some CPT codes that are related to either open, subtotal, or total gastrectomies, as well as minimally invasive gastrectomies, either laparoscopic or robotic. We looked at variables of interest. Our primary outcome was laparoscopic surgery, but we also collected data on demographics of patients such as their age, sex, preoperative comorbidities such as hypertension, diabetes, congestive heart failure, and also looked at postoperative complications such as readmission, reoperation, and mortality rates. Then we did a univariate analysis and also used our propensity score matching algorithm, where we were able to match one by one different patients, either white or black, and make sure that there were no confounding variables. So for our results, there were a total of 13,144 gastrectomies in our time frame of the NSQIP database. We excluded resections that were for benign cases and only looked at gastrectomies for malignancy, which turned out to be 5,000 cases. We saw that the white self-reported race, there were 3,900 patients, and 1,169 patients of the black self-reported race. So after we did the one-to-one matching algorithm, we were able to identify 1,100 patients of the white race and then the same number for the black self-reported race. So for our results, we saw a significant disparity between black and white patients for minimally invasive gastrectomies. We chose only to go for white and black patients because the data was sparse for Hispanics and Asians and other races. But as we can see, for open approaches, there was about a 50% either open or laparoscopic procedures for the white race, while for the Black patients, you can see that over 60% have the open procedure compared to laparoscopic procedures. And also you can see significance in comorbidities such as an age greater than 60, in sex, as well as for hypertension and diabetes, and also ASA class score greater than 2. Then we did our propensity score matching algorithm, which again showed this disparity between Black and white patients to minimally invasive gastrectomies. And you can see that there is significance with the p-value less than 0.008. We then took this data and we looked at complications after surgery, and we saw that there were no significance in post-operative complications, such as for readmission, mortality rates, or reoperation between Black and white patients. So as we can see from our analysis, we saw significant disparities in the healthcare field because of, or in minimally invasive surgeries. We think that there are multiple factors that cause this, some being socioeconomic status, and also differences in reimbursement and insurance, such as with private or also Medicaid insurance as well. We also have some variations in practice depending on geography, as well as in high volume centers, as well as small community hospitals. We also think that this difference is also due to some portion of implicit bias that all clinicians have that sort of change the way that we practice and deal with certain patients. And we think that the first part of changing this bias is to recognize it and consciously take steps to change our practice. So definitely for the limitations of our study, this is a retroactive or a retrospective study, and also although we can use this database to see national practice patterns, it doesn't give us the specifics on certain geographical areas as well as specific provider practices. I think an interesting future area of study is to look at specific hospital systems or institutions and see how their practice patterns hold up against the national data that we have. And just a special thank you to my colleague, Syed, as well as the other people who helped in this project, as well as our mentors, Dr. Merchant and Dr. Chokshi. And that's all.